So now we are going to start for hyperpituitarism. Okay, it can be acquired or it can be congenital. We are going to study the congenital first, then we'll go for acquired in the next video. So the first cause which is congenital is pituitary dysplasia. Pituitary dysplasia. The whole of anterior pituitary is affected and it is associated with craniofacial defects. Craniofacial defects. What are the defects? One is bifid uvula, bifid epiglottis. Epiglottis is also bifid. Cleft palate, cleft lip, cleft lip. In place of two central incisor, there is only one central incisor. And there is frontal bossing and depressed nasal bridge. This is pituitary dysplasia. Whole of anterior pituitary is hypopituitary, means the secretion is decreased. The second problem can be the transcription factor defect. Transcription factor defect. What are the transcription factors? PROP1, PIT1. PROP1 and PIT1. If these are decreased, there is decrease of ACTH, decrease of GH, decrease of TSH, decrease of prolactin. Okay. Another can be leptin receptor mutation. Leptin receptor mutation. Leptin is what? Leptin is the hormone which is released from the fat cells in response to the fat in our body. This causes the increase in growth hormone secretion. The receptor mutation will decrease it. So the main component is the syndromes. Okay, the syndromes. The syndromes, the most important one is the Kalman syndrome. It is a X-linked recessive syndrome, mostly common in the boys, that means. And X-linked recessive, what is the gene? Cal gene. What are the features? It is presenting with anosmia, hypogonadotropic hypogonadism, and there are 3C: color blindness, cerebellar ataxia, and cleft palate. Color blindness, cerebellar ataxia, and another is cleft palate. This anosmia is due to the agenesis of the olfactory bulb. There is lot of agenesis. Okay. Because of the agenesis of pituitary, it is causing hypogonadotropic hypogonadism. Because of agenesis of olfactory bulb, it is causing anosmia. Because of the agenesis of the cone cells, it is causing color blindness. Of the cerebellum, cerebellar ataxia. Of the palate, that is the frontal and the nasal processes, it is causing cleft palate, the palatal processes. The another syndrome is septo-optic dysplasia. Septo-optic dysplasia. This is associated with optic atrophy and hypopituitarism. Optic atrophy and hypopit. And the most famous, chromosome 15 paternal and maternal deletion. So paternal is P for P, Prader-Willi, and M for M is Angelman. Okay, M man. Okay, Angelman. This is maternal deletion. This is paternal deletion. What are the features of this imprinting disorder syndromes? The symptoms are muscle hypotonia, obesity, mental retardation, and short stature. Insulin resistance, early onset diabetes, small hand and feet. That is part of short stature. Small hand and feet. And the most important, they are always smiling. Happy puppet. Okay. Another syndrome is left, which is autosomal recessive. That is Lauren-Moon-Biddle-Barrett syndrome. Lauren-Moon-Biddle-Barrett syndrome. Lauren-Moon-Biddle-Barrett syndrome. What does this cause? This has many features which are like this. Okay. So this is mentally retarded and obese, and there are some functional features also. Along with this, there is hypogonadotropic hypogonadism, and the structural features which are present are horseshoe kidney, retinitis pigmentosa, and polydactyly. So what are the clinical features? These are the hormones which are less present, which are present in low amount. The most important is this one, ACTH, the first one to decrease, and the most important and the first one to be treated is the ACTH. Why is because the features are that of hypocortisolemia. What are the features of hypocortisolemia? The features are hypoglycemia, okay, hypotension, BP is falling, glucose is falling, and this is the acute episode. It presents mainly with increased abdominal pain. This is the feature of a secondary addition. Secondary addition. Okay, decreased BP, decreased glucose, and this is going to be repeated episodes. And long-term chronic features will be weight loss, asthenia, fatigue, anorexia. Okay, and the feature due to the ACTH decrease is hypereosinophilia. Eosinophilia. So, what are we going to assess? We are going to, when we suspect such a thing, we first are going to treat. Okay, what are we going to treat with? It's with hydrocot. If in the acute phase. If it is in the chronic phase, we are going to give hydrocot orally. In acute phase, IV. And in continuation phase, it is to be given 10 mg, 5 mg, 5 mg. Okay, total 20 mg oral hydrocot is to be given. And what are the tests we are supposed to perform to confirm it? That is, first is a insulin stimulation test. 0.1 microgram of insulin is given. With the insulin, we are going to have decreased glucose, that is hypoglycemia. And in growth hormone, we have studied that hypoglycemia triggers the release of growth hormone. But here the hypoglycemia will not cause the release because not growth hormone. Hypoglycemia is supposed to cause the release of ACTH, which will increase the cortisol, but that is to be more than 20. But in insulin tolerance tests, when insulin is given, the cortisol is not increasing and the cortisol level is less than 20 microgram. Okay, and we can give another metiropone. This is supposed to decrease the cortisol and increase the ACTH, but this is not going to happen because the ACTH secretion can't be done. So this will be decreased level of ACTH, matlab no response. Another is we give ACTH. If we give ACTH, the thing is reverse, confirming the diagnosis of secondary additions. Another is decreased TSH. Decreased TSH causes what? Cold intolerance, decreased heart rate, constipation. Lab findings will be decreased TSH and the management will be L-thyroxine. Okay. We are going to start with 50 microgram per day and we can titrate max up to 200 microgram per day. Okay. So now coming back to our favorite GH. So what are the features? The most important feature is hypoglycemia. What are we going to supplement? We are going to supplement with growth hormone only. 0.3 microgram per day. Milligram per day oral or 1 milligram subcut OD. We are going to supplement with this. And we are, what are the features? There will be hypoglycemia. The lipolysis is prevented by GH. So lipolysis is going to increase in decreased GH. So there will be increased triglyceride and increased endothelial damage. And we are going to have central obesity. So what are we going to do to detect it? We are going to go for provocative tests. We are going to provoke the release of GH, and if it is more than 3 nanogram, then it is normal. Okay, if it is less than 3 nanogram, then it is abnormal. We are going to provoke with many things. It can be glucagon, it can be clonidine, L-dopa, arginine, GHRH. Clonidine, L-dopa, arginine, GHRH. Prolactin, decreasing milk secretion in lactating mother. For FSH, LH decrease, it is going to cause decreased libido, amenorrhea, secondary amenorrhea, irregular cycle, hot flush, and it is going to cause disproportional fracture, and muscle wasting. So we are just going to supplement with estrogen and progesterone in case of females. In case of females, we are going to give estrogen 1 mg per day from 1 to 20 days, and progesterone 5 mg per day from 16 to 25 days. So and in males, we are going to give either GnRH pulsatile GnRH, or we can give testosterone. Now ADH, what is the feature? Will be anti-diuretic hormone is decreasing. So anti-diuresis is decreasing. So diuresis is increasing. Diuresis means release of water is increasing. So we are having diabetes insipidus, means the urine will be released, the urine will be released, okay, which will be very low osmolarity. So what is the management for ADH? For ADH we are going to give vasopressin or desmopressin. Desmopressin, it can be given nasally, intranasally, or it can be given orally. If nasally it's BD, or if orally it's OD. So we are done with the management. Okay.